I'm going to be talking about a bit of our meandering path over the last 4 years from an evaluation perspective. For those who haven't been here before, just starting out, I feel like this might assure you that there's, a path that we've all been moving along, and there's no perfect way forward, but again, collectively learning from our collective efforts. So I just want to give you a little bit of a context of where I'm coming from. I represent the Frontenac, Lennox, and Addington OHT, and so you can see the visual. Our attributed population is very close to our geographical sort of, I guess what I would say, boundary. So you can see that we have about 220,000 people in our FLA OHT, and we span both rural and urban areas, which not all OHTs do. So we have both of those lenses on our mind. We have a slightly older population. We have also a population that's fairly homogeneous from an ethnicity perspective. Approximately 95% of our people have English as their first language. We do have a higher proportion of French speakers at about 3% as well. Our focus in our region is very much from a primary care lens. Our flow-through agency is actually a community health center, so it keeps us very grounded from a primary care lens, and really that is our main focus in our OHT. And you can see we've got people around the out as core to our OHT. I'll just go through quickly, and I just want to highlight our mission, and this is like central to our focus from an evaluation perspective. Our objective is to have everyone in our region have a health home. And so again, thinking about that health home and primary care, and many people have heard, I'm sure Dr. Jane Philpott speaking now of her focus on a neighborhood sort of focus model, and that's very much informed our work and in turn our evaluation in our region. And I wanted to highlight this because this is our organizational structure. And I just want to say from the very, very beginning of our OHT, when we started to come together to write our application, evaluation was at the front and center of all of the discussions. So not only did we have to actually submit what our outcomes and indicators were going to be, but again, we were thoughtful from the start of how we can actually shape our work from keeping that evaluative lens to inform us as we went along. So you can see one of the core support structures is our evaluation group, which is on our transitional leadership collaborative as well. And you can see that all feeds into our primary working groups, which I'll speak to in a moment. So I'm going to share over the next about 10 minutes, which is going to be a rapid fire about what we've been doing, and just a little bit of a reflection on the last years, some of our key initiatives of focus, but really highlighting the evolution of our thinking. And Walter's sort of alluded to this evolution of even HSPN's work and support over the years. So our very first focus, we came together around our application and we identified our priority populations and indicators. And so our initial priority populations were 4 groups of people who are aging, people eligible for palliative care services, people living with mental health, and hospitalization. So again, we picked our priority populations. And really from there started to work with our communities to build what the actual interventions or programs are going to look like. So I wanted to put this as sort of our first building block. So we came together around these 4 populations, and then we had to develop frameworks around how we're going to create our interventions and programs. So again, very forward thinking in my mind from an evaluation perspective. Each one of these working groups had a community member co-lead, a primary care physician co-lead, and an evaluation representative from our evaluation working group. So we wanted to make sure we had the voices of all 3, remembering that primary care was sort of our prime focus. So over that course of the year, we co-designed what that programs were going to look like for each of these populations. And as part of that co-design process, and again, thinking about a logic model is really your program theory about describing what that looks like. So each of the evaluation representatives in the priority populations were tasked with helping to develop a logic model for each of the groups to help describe and also start to layer on what our outputs were, what our outcomes were, and linking those with both the CQIP indicators, but our TPA indicators that we were responsible for reporting back to. But just to share with you that each of the working groups, again, really worked with each of the groups to help start to describe what we were doing for each of those programs. And so the logic model was extraordinarily helpful for helping us to systematically document what we were wanting to do and the influence and the impact that we were wanting. And you can see, I'm not going to go in detail, we made sure we had TPA and CQUIP indicators, and you can see we used the quadruple aim as our guiding focus. In that very first year, so what we did was we rolled each of these, I'm not going into this in detail, we rolled each of our logic models for each of the 4 working groups into one visual for our OHT in terms of thinking about roll up of our outcomes. We also realized in that first year, so much of it was around co-design and describing the programs that we were starting to come together around, that we realized there wasn't any data per se in that first year. It was much about laying the foundation. So what we did from an evaluation perspective, we met with each of the groups and we actually held some focus groups to describe what the activities were and what were the success stories. So they weren't necessarily I met from data this outcome, but again, much more of a qualitative approach in terms of what did they think they met, what were the sticky points, and what work did they want to get to. And so this very much allowed the groups to feel like they were moving forward without feeling like there was something that they were missing in terms of implementation. So again, those very early days from an evaluation perspective. So that brought us, so again, thinking about our priority populations, thinking about how we used evaluation to describe what we're doing and also describing those stories of early success. And then we looked around the table, our evaluation group, which was a representation and still is of faculty members from Queen's who do evaluation work, as well as community members. And we realized what we needed in year 2 and onward is really the data that can start to help inform those programs to start to make changes and tweaks. And we realized, even though we keep talking that we're a learning system, and that should be we collected our own. And I saw in the chat that people talk about like this idea of missing data. And so we realized, and I've got this scale here because what I wanted to share with you is our big struggle. Our evaluation group is largely volunteers. I merely volunteer as the chair of the evaluation group. So I didn't at the time have vast resources that we could do a lot of primary data collection. I put the black box there because while there is access to large data, which can be helpful to sort of have a North Star look of where your OHT was, it wasn't the granular data that we needed to actually start to evaluate those test of change programs in those priority populations. And so we really struggled going into year 2 to try to get local data that we could action. And you're going to hear from Reham shortly about a great example of how they narrowed in on one target population and were able to get data. I will say that we struggled immensely. So we came together as an evaluation group and thought to ourselves, what we really want when we think about the quadruple aim is we want to hear from the people in our OHT and we want to hear about their health and well-being. So that started us on a focus in year 2 and 3 to actually reach out and see what it would be like if we created a patient outcome and experience measure. And we leaned heavily actually on HSPNs. We worked with 4 primary care organizations and public health and actually deployed what we're calling as our FLA OHT patient wellness and experience measure. And we're using part of the HSPN, thinking the EQ5D, as well as the Community Health Center socio-demographic questionnaire, so we can bring an equity lens. So we deployed it and tried it. And so we were able to get 1,200 experience surveys completed. And you can see we tried it in many different ways to see how best could we collect that data to inform our OHT. Not only did we collect the data from a learning health systems perspective, in that pilot stage, we actually gave each of the participating clinics back weekly and monthly data sheets to explain, what their patients were looking like. And so from that project, we really learned about, as an OHT, if we are going to collect our own data, our own prem and proms, what do we have to do to support our primary care network and our organizations? And what we learned really, this notion is that if we're going to actually collect data, one size does not fit all. And each of our partners is going to need significant supports to not only implement the data collection, utilize the data, and again, think about some changes that they can use from a QI perspective. So again, thinking about also shifting this lens in our OHT to think about, how can we make sure that we're collecting data to inform from a learning health system perspective as well. So again, just walking us through the first years, picking our priority populations, co-designing the intervention, describing it with a logic model, and trying to figure out how we can start to collect data to feed back into primary care, knowing that data is such a struggle. And so that brings us to where we are now. In year 3 and 4, which is where we're at, it's been largely a time to regroup, because many of you on the call here are probably trying to figure out where you focus your efforts. There's just so many moving parts in the OHT, so much going on. How, from an evaluation lens, can we have the most impact and inform the most different places in our system? And so those initial 4 groups have changed over time, partly from the information that we learned as we were developing the programs through the logic models, partly because new funding sources and opportunities have come in. And so in years 3 and 4, we were left with a whole different landscape and trying to figure out our small evaluation group, how we could most be impactful and how we can most be focused. So what we decided to do, and I don't know if people feel like this as well, again, most of us are volunteers trying to leverage the good work of our partners and the data that exists. But it's sometimes difficult to rein in and have a concerted, focused effort in terms of evaluation. And I'm just going to end here. So in years 3 and years 4, we've decided to tighten our evaluation group. We had a large evaluation group that we were meeting with regularly, and it was very hard to remain focused in terms of what our evaluation questions and goals are. We've become one of the 12 leading OHTs, and we've been able to hire Connor Kemp, who's fabulous, who's our performance and evaluation lead, who has a full-time role helping and support the work of Quest. And these are some of our other key colleagues on the Quest team. So we have decided to focus exclusively from a Quest group on looking at how we can evaluate the concept of health homes and this idea of having care closer to home through a neighborhood-focused approach. So we've honed down our logic model to think exclusively on the processes and the characteristics of primary care and the health outcomes associated with a health home model. So we've decided now to, again, frame everything around the health home in the last 4 years. And we're looking at 3 targeted activities for this year. One, we're focusing on getting the patient experience and wellness out to our primary care network. And we actually have a data support person that's going to be focused specifically on this role. We're looking at working to map our neighborhoods. And so we're working with the Community Health Profiles Partnership to actually break down our region into neighborhoods so we can start to align primary care with our neighborhoods in line with the focus of health homes. And we're in the midst of meeting with each of our primary care teams to look at the current state of where they're at in moving towards what we see as our health home model. So again, it's been a meandering path, starting from when we first got together to build our priority groups. And what we've really learned along the way is the crucial need to align outcomes and indicators across the many projects that will be happening in your OHT. Working closely, and again, Walter alluded to this, like with partners as much as you can to coordinate the data that's coming in. We have several large evaluations that are being conducted in various projects in our OHT, and working with those larger evaluation projects to make sure what the data they're collecting, how it aligns with our focus on moving to a health home. And again, thinking about really focused on that routine deployment of our patient wellness experience survey. We've heard from our council that what they really want to know is about the wellness and the health of the people in our networks, and really focused on getting that wellness data. So I guess I would say to everyone on the call, stay focused and have a plan. Bite-sized projects, again, we started very large and we worked our way down to much more focused, and build on your work slowly over time, each of your learnings, and we'll get you there. I'll just end on that last slide. Thank you.